Hi friends, welcome to Plexus Ortho. My name is Dr. Kannan Kumar and today we are going to discuss one of the MCQs that we put up a couple of days ago in the Telegram channel, and the MCQ was MCQ number 240. It's a very straightforward question. The most common cause of osteomyelitis is, it's very straightforward. The most common of any infection in the body in most places is Staphylococcus aureus, Staph aureus, right? Okay, Staphylococcus aureus is the most common condition. Others can affect, but the most common cause of osteomyelitis in all stages and all kinds of patients with all kinds of comorbidities is still Staphylococcus aureus. Okay, so a lot of students ask me this question. For example, if there is a patient with an IV drug user in the question and they give both the options of Staph aureus and Pseudomonas, I am of the belief that and all the evidence suggests that even if Pseudomonas is there in the question, the first most common organism is Staphylococcus, right? Pseudomonas is in higher frequency in these IV drug users, or Salmonella is in a higher frequency in sickle cell disease. But I think the most common cause of osteomyelitis in specific conditions is still Staphylococcus aureus. So if the MCQ stem or the answers contain Staph aureus, I would still take Staph aureus, right? So we don't get a key from these people who conduct the exam, so therefore we don't know what the exact answer is, but I would still take Staph aureus. So what is osteomyelitis basically? So osteomyelitis is the definition is in the term itself, right? Osteo means bone, myle means bone marrow, and itis is inflammation, right? So inflammation of the bone and its marrow is called as osteomyelitis, and that is basically infection, and it results from infection of the bone and the marrow. So that is osteomyelitis, right? So how does this osteomyelitis occur? How does it occur and how does it spread? The most common route of osteomyelitis is hematogenous. It spreads through the blood, right? In children, it spreads through lesions in the buccal mucosa or in the rectum, where the Staph aureus enters into the bloodstream and lodges itself in the metaphyseal region. It can also happen through direct inoculation, where there is a injury to the bone and there is a contamination to the outer environment, and this can also cause inoculation of the Staph aureus in the bone and can cause osteomyelitis. What else can cause osteomyelitis? You can also have scratches in the skin where the Staph aureus enters the blood and enters into the metaphysis. Okay, the most common organism is of course Staph aureus, because it's a commensal on the skin, and this can easily enter and cause infection in the bone, right? Why does it occur more commonly in the metaphysis? All of us know this answer very well. Because we have this growth plate when we are younger, the blood vessel that enters as a nutrient artery, it enters an ascending vessel and a descending vessel. The ascending vessel, which goes to the metaphysis, forms loop-like structures, right? They form loop-like structures in the metaphysis. And what does this loop-like structure cause? It causes stasis of the blood here. And because of the stasis of the blood, what happens? The bacteria gets time to get seeded there. So the bacteria enters there, and the metaphyseal region is the most common region where infection occurs, because there is a stasis of blood because of the loop formation of the vessels, right? And the second reason is the phagocytic function is theoretically supposed to be less effective in this area. Phagocytic function of our phagocytes and macrophages is reduced in the metaphyseal region, and therefore there is a higher chance of infection. So the two reasons why there is a higher chance of infection at this level is, one is there is looping of the blood vessels, and therefore there is stasis, and there can be bacterial seeding. The second thing is phagocytic action is less effective in this area, right? As we were discussing a couple of slides ago, some specific conditions are related to some specific organisms, but in all these conditions as well, I think Staph aureus is number one, and these are the number two conditions, number 2, 3 and 4 conditions, right? So in sickle cell disease, the most common organism that causes is Staph aureus, followed by Salmonella. Salmonella has a predilection in sickle cell disease. In IV drug users, Pseudomonas is known to cause osteomyelitis. When there's an animal bite, you have Pasteurella. Human bite, especially in the hand, MCP joints, when the human bite occurs when somebody is punching and you punch the mouth and the teeth goes into these MCP joints, they cause what is called as Aikenella corridans, right? This infection, osteomyelitis, can occur. Prolonged parenteral use can cause any kind of fungal infection. Remember this. So let us just repeat that one more time. Sickle cell disease is associated with salmonella. IV drug users have Pseudomonas predilection. Animal bites have Pasteurella predilection. Human bites Eikenella. Prolonged parental drug use can be caused by fungal infection as well. Okay, so let us look at the pathophysiology or the pathology of how this happens, right? So once the infection is seeded, you have the initial site of infection, and you have pus formation, right? You have infection seeding, the bacteria tends to grow, the patient or the child is having is toxic, is having high fever, then the abscess formation occurs. This occurs in about 24 to 48 hours, right? 24 to 48 hours. This will show up in the X-ray as a soft tissue shadow. It will show up in the X-ray as a soft tissue shadow, right? Then the abscess penetrates and then lifts up the periosteum, and it forms a proper subperiosteal abscess. This is called as a subperiosteal abscess. Okay, and this happens, and you can see it on the X-ray with the periosteal elevation in about 7 to 10 days time, right? You can see it in 7 to 10 days time. What is the best form of investigation that we can do in these cases? It is MRI, because even in initial stages, MRI will show bone marrow edema and infective changes. So bone marrow is the best investigation of choice when you have a high index of suspicion. In the early stage, of course, in the X-ray you will only see a soft tissue shadow, and later on you will see this elevation of this periosteum, and this is called as a subperiosteal abscess, right? If this becomes chronic, this is in the acute and subacute phases, where you see in the first 14 days to 2 weeks to 3 weeks, right? If this becomes chronic, that is, becomes more than 4 weeks or persists more than 4 weeks, then we call it chronic osteomyelitis. In chronic osteomyelitis, I'll show you an image later on, we can have what is called as a sequestrum, involucrum, cloacae. So these are some of the terms that you must know very well. So we will go on and discuss about these terms. So the initial phase, you have the abscess formation in the bone, that is, or pus formation in the bone. This ruptures through the bone, cortical bone, and elevates the periosteum, forming the subperiosteal abscess, right? And in the chronic phase, you have these sequestrum, involucrum, or chronic osteomyelitis occurring. So when do you call it acute? If it is less than 2 weeks, it is called acute. Subacute if it is 2 to 4 weeks, and is chronic if it is more than 4 weeks, right? Chronic osteomyelitis if it is more than 4 weeks. The child or the patient will present with exquisite pain and disproportionate tenderness and symptoms, right, to what you can see in the what you can see clinically in the initial phase. The child may become toxic, have high fever, and there is pseudoparalysis. What is pseudoparalysis? The patient or the child is not using the limb and is keeping it in rest, and so there's kind of a paralysis, but not actually because of muscle or weakness or any other kind of neurological problem, but because of pain and tenderness and swelling, the patient is not able to move the limb. How do you manage this condition? You initially start off with a broad spectrum antibiotic. You splint the leg, make sure there is no pain, right? What are the investigations you would get? You would get a CBC total count. You will find that the WBC count is higher, okay, and blood culture sensitivity should be done. It shows positivity only in 50% of the cases. Then serum procalcitonin is a newly available serum marker for early infection. So bone and joint infection, you can use serum procalcitonin, which is very sensitive in early infections, right? So these are some of the investigations that you can do. Also other investigations, as I was saying, you can do an X-ray initially, right? MRI is the most sensitive or the investigation of choice. You can also do a bone scan. It's more laborious, it takes more time, and MRI is much easier and faster to do. So in the question options, if you have MRI as you should choose MRI as an investigation of choice, right? So what happens, we will discuss about chronic osteomyelitis in more detail in another video, but what are the things that happen in chronic osteomyelitis, right? So when the pus formation occurs, the bone, surrounding bone, undergoes necrosis, ischemic necrosis. It is cut off from its blood supply. becomes ischemic necrosis. Once it becomes ischemic necrosis, it is walled off completely, surrounded by granulation tissue. That is a pathological process, right? So sequestrum surrounded by granulation tissue, and the sequestrum is a piece of dead bone which is surrounded by granulation tissue. That is the definition of sequestrum. Then new bone formation tries to wall off the infection and keep it there, and that is called as involucrum. New bone formation walls off the infection, keeps the sequestrum and its granulation tissue in its place, prevents further spread of the infection, and this is called as involucrum. Involucrum. So you have the first term that we have to remember is called as sequestrum, dead piece of bone surrounded by granulation tissue. The second is involucrum, attempt at new bone formation around the sequestrum is called as involucrum. Over a period of time, the involucrum gives way and there is a sinus, or there is a pathway for the discharge to happen, pus to come out, and these openings are called as cloacae, right? Sequestrum, involucrum, cloacae. Remember this is very often asked, and you must know it very clearly. And the various types of sequestrum, we have discussed this in another video, and we will further discuss in future videos as well. So these are the parts of the of a chronic osteomyelitis, right? So in brief, what have we discussed in this question and this video? The most common organism in osteomyelitis is Staph aureus, irrespective of the patient condition. Okay, is Staph aureus. And what are the pathophysiological phases in which this infection occurs? Why does it occur in the metaphysis? Two reasons. One is because of the coiling or the looping of the blood vessels, because of which there is stasis of blood and there is improved seeding of the bacteria. Second reason is phagocytosis is less effective in this region. Okay, and we call it acute osteomyelitis if it is less than 2 weeks, subacute 2 to 4 weeks, and chronic more than 4 weeks, right? Acute can become chronic if it persists, and the various parts of a chronic osteomyelitis include sequestrum, involucrum, cloacae. What is the investigation of choice which is for osteomyelitis is MRI. X-ray changes are seen usually by 7 to 10 days, and what is the first X-ray change that you see? You see the periosteal elevation because of the subperiosteal abscess, right? So with that, we come to an end of this discussion about this osteomyelitis regarding this question. We will meet again with another discussion. My name is Dr. Kannan Kumar, and this is Plexus Ortho. Thank you very much.